Good Wednesday morning, halfway through the work week, 4 minutes past 10 o'clock. We're already up to 81 degrees at KRIM Studios on West Frontier in Payson. This morning on Community Spotlight on KRIM, I'm going to be talking about some really special stuff once again that has been born out of the MHA Foundation and a lot of great people here in RIM country. And it really promises to, I don't know, just add a lot of extra benefit to the future of medical care, not only here in RIM country, but all over the place. With us to tell us a little bit more about it in the studio today, we have my friend Dr. Alan Michels. He's the CEO of Ponderosa Family Care, also Chief of Staff over at Banner Payson Medical Center, and also a third-year med student from the U of A Phoenix. That's Selena Burhan, and we're going to find out a little bit more about all this. And I guess just to get the ball rolling, Dr. Michels, let's first set the stage with how this all got started. Now, you've got med students from U of A that are coming here to Payson, and not just for a short period of time, but they're actually here for quite a while, being able to get their head and their heart wrapped around the needs of medical care for the patients here.
That's exactly right. It was born out of Dr. Hunt and myself working at Payson Christian Clinic, trying to educate more students in what we call whole person care. So it was really oriented around, this is not a person that has a medical diagnosis or a person in exam room 3. It's really a patient that has a medical condition that's a whole person that maybe has values wrapped around what this new diagnosis might be, worries about how things are going, and sometimes homeless people, where we've had homeless students that get recurrent ear infections or pneumonias, and we find out that they're living in a car in the forest. And so whole person care was to encompass that idea that says we care about the whole person, not just a clinical diagnosis. So as we began educating more and more students, I think since 2016, Dr. Hunt and I have lost track, but it's the students that we brought here to Payson is along the lines of 350 or 400 students.
Wow.
Nurse practitioners, physician assistants, and this very special program with the U of A that we'll describe today is really about the medical students at the College of Medicine in Phoenix.
Okay, now we're talking about the longitudinal integrated curriculum. Explain what that means for those of us out here that don't have a clue just hearing that title.
Well, traditional medical education, we felt, was missing the mark. So, for example, if you look, I came from Nebraska, and we had a lot of rural medicine electives. And the longest I ever spent in any one place was 4 or 8 weeks of time. And if someone came in, the example we used, I think, last time we were on the air was if someone came in with abdominal pain and we thought it could be their gallbladder, then we'd send them for a CT scan, and I might be onto a new rotation at that point. So I may never see the patient again and understand how that worked. And this new idea say, well, the student really needs to understand what the patient goes through and identify better with that patient experience. And so they would go with them to the CT scanner and actually see how that's done and talk with the radiologist, interpret the images with the radiologist and see what they actually do. They come back to my clinic, and we might send them then to the surgery clinic, and the surgeon might take a look at the patient, the CT scans, and then the student would be right there with the patient, following a patient in a cohort of patients that they had that were going to train them in specific things, follow them through the hospital, and then post-operative care. And so that student got a much richer experience, but sometimes it takes a longer time. So this program is set up for, out of 24 months of clinical rotations, 9 of them are contiguously in Payson. So they start in their 3rd year, and they begin in rural health training with being in the rural area, immersed into our culture and understanding some of the limitations in healthcare, understanding what patients do and don't want.
And this kind of curriculum is not something that was available back when you were in med school.
Yeah.
And so, I mean, you're seeing firsthand that you believe this is a big step forward.
Yeah, and this is really, the University of Arizona Phoenix program was, the College of Medicine was thinking about doing a program like this. We kept having students come back from working with Dr. Hunt and myself saying, but I want to understand what internal medicine and pediatrics is like, and I think I want to do that. And they came here maybe wanting to do a different specialty line. And then the U of A began coming up here saying, well, what are you guys doing that's so different? Why are they so energized, and why do they really love rural medicine when they come back to study with us? And so they began to say, well, is there something that we could do with Payson and form a formalized LIC program where they could be trained 9 months out of that period of time. MHA Foundation found a way to gel all that together with their contacts at high levels in the universities and trying to help rural medicine. And that's a part of their mission, is to say, how do we serve the people of our area to give them the best of medical care? And how do we train our practitioners to do that? And training students from the very earliest part in their clinical education was a part of that mission.
Very interesting. And as I mentioned, also with us in the studio, Selena Burhan. She's a third-year med student with the U of A Phoenix. And Selena, how long have you been in Payson now?
I got here in April.
Yeah?
Yeah, so quite a few months now.
So what's the experience been like for you so far?
So it's actually had a little bit of everything, I think. When we started off, we did a lot of the COVID efforts with Dr. Michels, doing a lot of the screening portion. So it was a lot of that at the beginning.
On telemedicine, I might add.
Oh, yes.
They
yes,
were not allowed to see
telemedicine.
patients directly, so, yeah.
Yeah, so we did a lot of the telemedicine portion, which was really neat because I don't think a lot of times that's part of our curriculum normally for medical school, integrating that telemedicine aspect. And especially if you're interested in rural medicine, telemedicine might be something that you'll end up doing and really get some benefit out of it. And so that was really interesting to me to learn as far as that part goes. And then once we were able to get access to really see the patients, that really changed as well. And it was really neat starting off with all the different specialties and being able to see the patients here in Payson and learning more about them, not just about their health, but also about their living situation or even just their families or what they like to do for fun.
You know, and I gotta just hit on that telemedicine component for just a moment. Dr. Michels, I know that you have a history with telemedicine that goes back before most people knew how to use the word in a complete sentence, and you and I have played a few telemedicine games internationally with disasters and stuff. But one of the things that I found really interesting, you know, we started doing that back after the 2004 Indonesian tsunami, but telemedicine was, you know, wasn't really even, you know, used much at all at that point. And now since this pandemic thing, it seems like there's been a lot more people in the medical profession that have been, well, I guess, you know, for all intents and purposes, forced into using it. But I've been hearing from a number of places that it's people's opinion of it and their acceptance of it has really grown, where even after this pandemic is over, the chance is pretty good that we're going to see a lot more telemedicine being used.
Yeah, I sure hope so. As you know, I'm fond of saying it was the late 80s and early 90s when I was working on it at the University of Nebraska Medical Center. We didn't have a name for it. We were simply trying to give cardiology care where there's only cardiologists at Omaha and Lincoln in that day. In Nebraska, some of the hospitals 450 miles away. How do you help stabilize a patient where they are and fly them to where they need heart surgery or intervention at a point at which they're stable? And that might be days of time. And how do you help a rural practitioner stabilize them where they are? And that's where we began. And so we set up remote monitoring and things. Then you and I had used it with the tsunami. We've done care in the Philippines. We've done all kinds of different things in India. You know, one of my remember was I had given you some questions about night sweats and other things in case there had been tuberculosis.
Right.
Someone came into a camp in India that you had set up, and the people had night sweats, and so then it turned out both I think it was a boy, a young boy, and his mother, both had night sweats. And what we were trying to do was not bring tuberculosis into a camp of 6,000 people and spread tuberculosis. So based on that, then we got other people in the community involved and then provided funds for the local pharmacy and the local doctors to provide that treatment and take it from there. So that was what you and I were doing, and so we diagnosed with digital stethoscopes from 3M, if you recall.
Yeah, at about 10,000 mile distance.
Yeah, and we heard crackles in the lungs, put the clinical puzzle together and saved that camp from getting tuberculosis untreated.
A prize photograph that I have is of me with the digital stethoscope on the back of the young boy, and now when I look back at it, I think, you know, probably should have brought some masks along in that trip. But we didn't know what we were getting into, or at least I didn't. Anyway.
That's some of my history with telemedicine, and I've been a proponent ever since. And honestly, I've been speaking to this for a long time, but the thing dragging its feet was the insurance aspect of that, getting things paid for.
Mhm.
And so now with COVID-19, it's very clear, gee, you don't want people with an infectious illness coughing on others in the waiting room.
And they've relaxed a lot of the restrictions of when, you know, what you could do in that kind
So
of thing.
finally, with a pandemic, then people came to this idea, well, I don't want to be in the waiting room. And then the insurance company says, well, we don't want you there either. And so
Right.
now with the idea of payment coming along, I think it's going to kind of press into our healthcare system the need for this on an ongoing basis.
And you're able to, because of some of the restrictions being relaxed, you're able to use kind of mainstream mechanisms like Skype and Zoom and things like that for telemedicine,
Absolutely.
where beforehand you weren't able to.
And some of those, we seem to have somebody who's hacking all the time, and so there have been programs that have been hacked into, but the idea of HIPAA-compliant programs
Mhm.
that Skype didn't used to have, and now they do. Zoom didn't used to have, now they do. So you're finding that even Google has platforms that are HIPAA-compliant, and that's simply the lingo for privacy is respected and protected for the patient.
You know, Selena, one of the things that I know Dr. Michels briefly mentioned, and I know we've talked about here before, is the experience that you students have in a rural setting versus maybe working in one of the metro hospitals in Phoenix and that kind of thing. What's that experience been like, that difference between, say, Payson Regional Medical Center and Payson Family Care and those kind of experiences? What has the difference been for you between that and, say, some of the metro facilities in Phoenix?
Yeah, so I think that as starting your third year of medical school is when you're really going to start to see patients, and it can be really intimidating, trying to put into practice what you learn. And being here in Payson, it's really helped me feel more confident in my skills. And I think it started off because Dr. Michels was actually my first teacher here.
She got stuck with me.
And you're still here.
I'm still here, yes. He was amazing.
Yeah.
Yeah, and so I think like learning from him at the beginning really helped me figure out my skills and learn from him. And then all of a sudden I was like transferred to a different doctor, but then Dr. Michels knew that doctor and everyone else knew that doctor. So, and all the patients know everyone. So I think it really gave me the skills to not only be able to talk to a different doctor about what's going on, what we've already done, but it also made me more confident in my abilities of taking care of a person and learning from the different specialties too. Just because I stopped working with Dr. Michels, like for the full month or so with him, it doesn't mean I completely stop.
Right.
I still talk to him, I still see him, which is really nice. Versus in the valley, I'd be with a doctor for maybe about 4 weeks and then probably never see that doctor again. And here, I that doesn't really happen. I just finished surgery, but I'm still going to work with the surgery department.
Okay.
I still work with family medicine department, so it's really nice. And it takes away that intimidating portion.
Sure.
So do you feel like if you had a surgical case, for example, you're working at my clinic, do you feel like now, just a couple months in, you'd feel comfortable calling that surgeon and say, hey, we've got a concerning case?
Oh,
Here's
100%.
Yeah.
Yeah.
And what if
but-
they ended up in the emergency department?
Yeah, so actually today's my first week in the emergency department.
Oh boy.
Yes, and so I think honestly that's what is really nice about this, that yes, I feel like I could call that doctor. The doctor hopefully would remember who I am and be confident that I'd be able to give them a good presentation of what's going on with the patient.
And one of the things too, Dr. Michels, and I know that you made comment on this before, is that in the past, it has not always been easy to find physicians who want to live in a rural environment, especially if all of their experience has been in more of a metro facility. Is this something that could really help in the long run as far as being able to attract the next generation of physicians to actually come and stay right here in places like Payson?
That's exactly what MHA Foundation is trying to do, is create a culture for developing people that want to be and are passionate about being in rural America, and particularly in northern Arizona as we see it. So Gila County in northern Arizona. So that's exactly the culture they're trying to create. So we want them involved in schools. We want the students involved in leadership in our community. We want them to immerse themselves into this and take them to homes and let them see this is how we live, So yeah, exactly. But if you recruit somebody so that they're just trying to pay off their student loans, then it's a very different type of environment where they might come and they do 1 to 3 years in an area and say, I can't wait to get out of here, right?
Right.
So they work really hard during that year. They might not know anybody in the community to that depth. And we're trying to do the exact opposite. So it's a culture change that the MHA Foundation is facilitating.
Now, on the flip side of that coin, I know for you personally, there's some challenges that come with the small town thing, because I know I've been out to lunch with you before, and in very
I've been thinking you're out to lunch.
Yeah,
You're out to
you and a
lunch.
whole bunch of other folks. Yeah. But it seems like invariably, while we're sitting there visiting, eating lunch, somebody has to come up to the table and say, "Oh, Dr. Michels, I got this pain in my back."
Yeah.
Where you might not really get that kind of exposure to people that know you in the metro area. So there's some interesting twists and turns to this on both sides of the equation.
There is, and you begin to develop a certain personality in the community as far as that goes, where you're trying to help, where you might see someone at church, you might see someone at the grocery store.
Right.
Some funny stories I could share about that. But
we'll do that later tonight on catering.
Gee, Dr. Michels, I have this rash below my belt line in the candy aisle. So no, thank you. I'll see you in the clinic. But yeah, so what we're trying to develop is a personality that says, okay, we help you get out of your shell to a certain degree,
right,
but to your comfort level, to connect with people. And when you only see someone for a few minutes at a time in a clinic setting, and that's the only time you see them, especially if it's a very limited number of times per year, let's say, then you don't develop that kind of rapport and that kind of ability to help. And rural practitioners very, very commonly are called to help in new and different ways. And so sometimes what we need to do is have that, I think of this as a telemedicine piece, where it's like, I can video conference with you right from your house. It's Saturday night. I don't think what you need is the emergency department. I think you simply need me to take a look at your child's throat, for example, and if we see what looks like a significant infection now that it's been 8 or 10 days, perhaps they need some antibiotics and save you the emergency department visit. So these are some things that then can be done for that on-call physician with a
right,
telemedicine piece blended in with a culture that embraces whole person care.
Well, I know in my personal situation, you've been my physician for quite some time, and I needed to get a prescription renewed for some blood pressure meds that I take. And of course, now with all the COVID stuff, everyone thinks about, and I'm 61, and I'm thinking, you go in and you expose yourself to perhaps a lot of sick people in a clinic setting and that kind of thing. It doesn't really sound like something I would choose to do if I could help it. And you very quickly just said, well, let's just do a telemedicine visit. You had some questions to ask. We went through all of that, and boom, my prescription gets refilled.
Right. Yeah.
That seems like it would be, good on the patient end as well as the physician end.
Yeah, there's good points, and then obviously if you're the person on call, it may lead to some additional visits where people waited to do that until it was the weekend. Well, we try and fit things inside that sort of business, but when I talk to people in the rural community, people know what I've been going through with my family, and so you just try to have a certain openness of saying, well, gosh, my parents are going through a tough time right now.
Right.
I need to be out of the clinic here for a while, and usually people embrace that and say, oh, absolutely, I went through that too, and you should be there for them. Or if my son is in a sporting event, oh, as a dad, you should be there. So there's an understanding on the other side as well, that there's a personal boundary on the one side, a professional boundary on the one side, but on the other hand, that you really care about them as individuals, and they care about you.
Mm-hmm.
And so that connectedness gives you a completely different feel, I would say, wouldn't you, Selena, in a rural area?
Yeah, it definitely does. You really get to start to make connections, even just as a student, to make those connections with all the patients that you see. And then it's interesting because then you form a connection in the sense of, I'm new to Payson, and everyone I think has recommended me a trail to go do, or everyone has told me, so what brought you here to Payson? And you very quickly start to make those connections with people.
People tell me to take a hike all the time. So if
It's part of that going out to lunch thing.
Yeah,
Out to lunch,
exactly.
take a hike.
Has there been any aha moments for you? Where just kind of a sudden epiphany of the difference being in a rural? Have there been some big points that was like, wow, I wasn't expecting that?
Yeah, so actually, I think that part of my aha has been what I had mentioned prior was that I've learned that I can do more than what I thought I could do.
Right.
And I think that having really great teachers here has really helped that. And even just the experiences that I've had working with the different doctors, it makes me be like, okay, I think I want to do this specialty, and then I work with another doctor. I'm like, I think I want to do this specialty, and so then I jump from one to another just because they're all amazing, and you can really tell that they like what they do. And I always think, you know what? That's the kind of doc I want to be. I want to be a doctor that enjoys what they're doing.
Yeah, life's too short, right? You gotta love what you're doing.
Well, and what if you get to a point, Selena, where you reach the end of what that practitioner knows, or what the entire community of knowledge knows? How about some of the telemedicine applications that, as we look at what we're developing is called really so the integration of a medical practice and the educational parts we've called rural medical collaborative healthcare innovation. So as you think of the incorporation in of the telemedicine piece along with our community resources, and even those that come from the outside in are limited to a certain degree. We've gone over some cases with using telemedicine where we've taken them to levels that are way beyond what patient can handle. Describe that.
Yeah, so we, like Dr. Michael said, we've definitely had some cases where you have to realize, we're in a rural community, we don't necessarily have every single specialty here, or we don't have the resources to take care of a patient that's more complex. And so Dr. Michaels and I also have had the opportunity to do that where we have patients that have more complex cases, and we've been able to utilize telemedicine to consult with specialties that are not here near us, but that would be able to help us take better care of the patient.
And are perhaps only 3 in all of Phoenix.
Yeah.
Right?
Yeah.
So we have practitioners we pulled into cases that where there had been a history of medical treatment that resulted in significant scarring, perhaps an autoimmune reaction, heart rhythm problems, had incorporated in breathing and airway problems, and with all of that together, there is a person from Cleveland Clinic, formerly from Cleveland Clinic, and now since then has relocated down to Phoenix area, but we pulled in people that were very specialized for that case, and honestly saved a person's life by pulling in that expertise via telemedicine.
Well,
so
and you also,
that innovation was big.
Yeah.
Huge. Now, you also had a situation here a few years ago that I'm familiar with, Dr. Michaels, where you were doing telemedicine consults with a neurosurgeon out of the valley for people that had chronic spinal issues, and things were to take that drive for them to take a drive all the way down to just maybe do an initial consult with that neurosurgeon who's just going to put them through a range of motion study or something like that, would be really uncomfortable for them. And you were doing that via telemedicine. Has that type of thing, I mean, obviously it keeps them comfortable, keeps them at home until they actually have to go for surgery or whatever, but has that been growing, that kind of service?
Yeah, I would say it's a common part of what we do as everyday practitioners in primary care and specifically in the rural area, but this should be true any place. A case that I think you're referring to was a neurosurgery case where it's an 84-year-old woman who we had one of these huge dumps of snow, and she shoveled her own sidewalk. And after getting done with that, the following morning she couldn't move her legs, couldn't stand. And so she had some paralysis that was going on, lost control of bowel and bladder, some real red flags, but previously had been healthy. And we did a telemedicine visit, and even without MRIs, it was clear to the neurosurgeon, I can tell you what you have. You have some spinal stenosis from the heavy lifting that you did with that snow. And if we don't do surgery, you're going to have some permanent nerve damage. And so I recall it was a Tuesday, and we did a telemedicine visit on Wednesday when she couldn't walk. And by Friday, she was walking again after having surgery.
That's amazing.
In the same week. And it's just amazing.
Now we're almost out of time, but Selena, have you decided yet what kind of area you want to specialize in, or are you still just experiencing all the different modalities?
I am still experiencing everything. I'm still very open-minded about what I would want to do. Like I said, I have enjoyed my time learning from the different specialties. So still exploring. We'll see what ends up happening. But I do love this rural medicine experience that I've had. So I definitely think I would want to continue practicing in rural.
Beautiful.
Most of us have no papers to our name. How many papers do you have your name on now?
Oh, yeah, so I do a lot of research. So I've had, I have 2 publications, I have 2 pending, and still working on
Invented
more.
any of the things that you and I have talked about? So we're working on device inventions and simple things
Oh,
like
wow.
that. So,
Yeah.
yeah, so this Rural Medical Collaborative Healthcare Innovation is really a new effort. It's we're really excited about it. We love having the University of Arizona College of Medicine students here for 9 months continuously. That's just such a great experience for them, and it's so good for us as well. Of course, we would hope that a Selena or someone like that would stay in rural medicine. And whether they stay in rural medicine or they choose not to, we hope they have the best of education. But then, along with the help of MHA Foundation, we're trying to find ways to have them stay where they can have an impact. And but we hope some would stay here.
Yeah.
We hope some would stay here.
Outstanding. Well, hats off to the MHA Foundation that has really been able to make this happen. And also to folks like Dr. Alan Michels, Dr. Judy Hunt with Ponderosa Family Care. I just think that, when you go back, I've been around Payson for about 40 years, and when you look back not that long ago, healthcare in Payson was a significantly different critter than it is today. And I think a lot of it is due to the great work of people like Dr. Michels, the MHA Foundation, and certainly where technology is going. Selena, best wishes for whatever avenue you choose to go down next. I'm anxious to hear more about some of these papers that you've been published with. That sounds kind of exciting, especially as a med student. That's really amazing.
Thank
I got
you.
one last plug I'd like to
Sure.
throw in there, and Selena has mentioned this, but there are many practices involved in this whole effort. The hospital involved in this. This is a whole community effort.
Mhm.
She mentioned surgeons. They obviously don't work out of Ponderosa Family Care, but
Right.
Payson Surgical Associates. Dr. Booth and her office has been involved. Most clinics in town, I think, have had a participation at one level or another, and certainly the Banner Clinic, a lot of participation.
Nice.
And so, I just have to applaud the whole community of practitioners for educating the students and making them better.
It comes back to that whole small town atmosphere thing, the kind of collaborative focus that might not be as easy to obtain in places like Phoenix.
Yeah.
I'm putting it nicely.
We're really pleased.
All right. Thank you both. Again, we've been talking this morning with third-year med student from the U of A Phoenix, Selena Verhen, also Dr. Alan Michels, CEO of Ponderosa Family, CEO and Chief of Staff at Banner Payson Medical Center, and CEO at Ponderosa Family Care. I'll get it right, yeah. Alan, anyway, thanks to both of you for being here with us this morning. We
Thank you.
appreciate it.